So our standard of care, unfortunately, has not changed for a long time, really now over 15 years. And so for higher risk patients, and maybe just to take a brief background, I think who is higher risk, I think is at least a comment. So I think there are higher risk categories by IPSS, or if you use IPSSR, which is the most commonly clinically utilized score, is intermediate to very high risk patients. But now we have molecular modeling. The IPSSM is really the new model that will likely be sort of the standard going forward. There's now 6 categories. So again, the top 3 you could say are higher risk, but I think how we incorporate that from a treatment perspective, I do actually think needs to be answered in prospective and in a lot of real world studies at the same time. But let's say a patient's higher risk and has an indication for therapy, which is kind of its own discussion. Hypomethylating agent therapy has and is currently our standard, with a little or slight preference for 7-day azacitidine, as that's the only agent really ever in a phase 3 trial to show an improved overall survival versus sort of conventional care, at least at that time. So while we're thinking about hypomethylating agent therapy, we really at the same time need to be thinking about, can a patient go forward with allogeneic stem cell transplant? So we really know up to the age of 75, if a patient is otherwise fit, that long-term survival is significantly improved in patients that go to transplant versus not. So it's really a key question, really from even before you start your first day of azacitidine, do you think a patient will ultimately go forward? We at least start that referral process. In general, the standard, regardless, is patients will start on it. If they cannot go to transplant, it's sort of azacitidine indefinitely, versus if they can go to transplant, typically patients may get 3 to 4 cycles, at which point they're ready for transplant, and then we go forward. I think, does azacitidine improve outcomes to transplant has actually never been proven. And you can make an argument actually in patients, let's say without an increase in blasts, particularly less than 5 and maybe even up to 10% blasts in some patients, could we just take them directly to transplant? I think many people are concerned just given the amount of time that could entail. But let's say if a patient could have a sibling donor or potentially more rapidly expedite evaluation, you can make an argument that direct to transplant is just as good as sort of pre-treatment with hypomethylating agent therapy. I think that being said, there's a lot of exciting combos that we'll talk about in a little bit. And the hope is that with these combinations, we're getting better molecular responses, which actually will translate to increased cure rates to transplant, maybe improve functional status from getting hematologic improvements. And if you look at early data for patients on some of these novel combinations, actually the transplant survival data have looked quite encouraging, albeit it is a little bit of a biased population, a fitter population, patients that are on clinical trials. But again, essentially standard of care for high risk is hypomethylating agent therapy, indefinite therapy versus considering bridging to transplant. But I think the challenge is right now is that, again, more than half of patients don't respond to therapy, and we're really looking for the new combination that will change our standard of care.